The Nkqubela COVID-19 response team has been very busy in the last week getting Nkqubela Hospital ready for the COVID-19 pandemic. Due to social distancing, we're unable to run large in-services and large trainings for the staff, and we're therefore hoping this presentation can help make sure that every staff member at Nkqubela Hospital knows exactly what this plan looks like. This particular presentation is going to be focusing on the zoning for COVID-19. So we've looked at the whole hospital and we've divided it up into different types of areas, and you can see we've allocated them with 3 different colors. So our blue areas are where we at the moment would say there's a very low risk that people in these areas have got COVID-19. So for example, patients have been on the ward since before lockdown. Our second areas are our yellow areas, and these are our entry areas. So people coming into the facility and we don't know whether they may have COVID-19 or not. And then our orange zones are those patients who might have symptoms, or we might have concern there is a risk that they could have COVID-19. Let us just quickly list these key zones, and then we're going to go through them in some detail. Firstly, there is everybody who enters through our gate. Secondly, all our visitors who arrive will be screened at the gate. Thirdly, all of our patients and their escorts who arrive for outpatient review visits or for admissions will be screened in the outpatient zone. Fourthly, any patient who is found during review to screen positive for symptoms for COVID will be seen by the chest clinic, which will be the doctor screening those patients. There will be COVID-19 testing zones and outpatients, for example, for patients who screen positive. Then we have quarantine admission wards. These are patients where we've tested them for COVID-19 and are still waiting for results. And then the rest are what we would call blue zones. So those are normal wards, receptions, admin blocks, etc. But all of these entry points, we still need to make sure that we protect staff and patients who come in and out of those areas. Firstly, let's look at our yellow zones. So these are patients that are, or people who are entering our facility. Our first very important zone for this is the gate sanitation zone. So everybody enters through the gate, whether it's staff or service providers or relatives or patients, and they all need to have thorough hand cleaning and sanitation done on arrival. So at the gate, ideally we want at least 2 security guards to be managing that point. The one security guard or the gate designated official needs to make sure that people don't crowd when they're queuing. So for example, if a lot of patients or staff are arriving at the same time, they're all standing 1.5 meters apart while they're waiting for their hands to be sanitized. And he'll also be in charge of the register and to make sure the register gets signed for gate control. The second person is the sanitation designated official, and he or she will be sanitizing the hands of each person that enters the hospital. The PPE for the staff, at the moment, because of the TB IPC, our staff members are all using the N95 mask, but they will be using this now continuously, whether they're inside the security building or whether they are outside. There will be social distancing at all times, so our security staff also need to be aware to stay at least 1.5 meters away from others at all times, and the regular hand hygiene, very important also for our staff. The next important point is our screening station, which is going to take place in our outpatients department for all the patients and their escorts that are arriving. For screening, we have cordoned off an area at the entrance of the outpatient waiting room. Patients will still be reporting their name to the admin office window, and then they will be queuing outside the waiting room 1.5 meters apart. This screening area will be staffed by a nurse, and each patient as they arrive will be handed the appropriate mask depending on our TB IPC measures. Hands are sanitized, and the nurse will then complete a screening questionnaire sitting 1.5 meters away from the patient and take an infrared temperature at this time. Any patient who's screened positive to either a contact history of somebody with COVID-19 or who has any new symptoms in the last 14 days, so a new cough, new fever, a new shortness of breath or new sore throat, will then be put in a separate queue where they'll be sitting probably outside if weather allows, in seats 1.5 meters apart. And that nurse will bring those notes directly to the doctor at the chest clinic. If the patient screens negative, then they can wait in the normal waiting room, but still 1.5 meters apart. The PPE for our staff member who is screening, she'll be wearing an N95 mask as per our TB IPC, an apron, and will be sanitizing her hands between each patient. The second very important place where we are screening is for when visitors arrive in the afternoon. At the moment, that is restrictions on visitors only being allowed to come between 3 and 3:30, one visitor per patient per day. And an area has been made available in the security office that will be staffed by a nurse member who will be doing the screening. Visitors again must queue 1.5 meters apart while they're waiting to be screened, and each visitor will be handed the appropriate mask, again depending on the TB IPC measures. In our hospital, that usually means an N95 if they're coming into our wards. Hands are sanitized and the screening questionnaire is completed and the temperature taken. If a visitor screens positive, so any of the symptoms or any contact history or any travel history, they cannot unfortunately on that day visit the relative. They must be counselled very well. If any messages or things need to be conveyed, that must be happening. But they must report to their own facility for testing. We can't test and provide COVID-19 services for visitors to the hospital. If the visitor screens negative, then they can progress to the ward. Our PPE for our staff at this point is our N95 mask, again according to our TB IPC, an apron, and they'll be sanitizing hands between each patient. We're now going to move on to our more riskier areas, and these are the areas where there might be a risk that our patient has COVID-19. They will get tested or will be waiting for test results, and we need to make sure that there's no risk of cross-contamination whilst we are awaiting those results. So firstly, I want to just quickly talk about stretcher cases arriving at outpatients. So there's always a risk when an ambulance, for example, arrives with a patient who is very ill, that patient might have COVID-19. But unfortunately, we don't want to bring them in an outpatient space where it's very busy. We have one stretcher room where a lot of people are passing through while we're waiting to find out whether that patient may or may not have COVID-19. So we've made an interim measure, and this will only be on Tuesdays and Thursdays. So those are our review days where it's quite busy, and we want to reduce congestion in that outpatient stretcher room. So Dr. Muller at the moment, myself, is our COVID contact doctor, and on Tuesdays and Thursdays, any EMS that arrives with a patient, Dr. Muller will be contacted. We will look at the referral notes and make a decision on where the most appropriate places for that patient to be admitted. So if they're going to be admitted to Nkqubela, they'll be sent to one of our quarantine wards. So the EMS, instead of bringing the patient into OPD, will take the patient directly to those wards, and a file will be opened by our admin department as per usual in the meantime. The file will go with the doctor to the ward, and the patient will be clerked, therefore, in a quarantine ward by Dr. Muller and the professional nurse on duty on that day. All of our new admissions coming in, whether they screen positive or not, we will be testing for COVID-19. And in the quarantine ward, we have our routine quarantine ward PPE, which is our N95 mask as per our TB IPC, aprons and goggles. On Mondays, Wednesdays and Fridays, OPD is not busy, and that stretcher room is open, and so therefore our patients will still seen by the doctor on call as per usual. Our next important screening area, which is our second screening area, is for those patients who's now arrived at OPD and they've screened positive for either symptoms or contact history of COVID-19. And therefore, instead of mixing them with the normal flow of patients through OPD, they will be waiting outside on designated seats and will be seen by a designated doctor in what we're going to call the chest clinic. At the moment, that is a room in our OPD. It's that closest room to the waiting room on the right. And all patients who are screened positive will be going to that room. And it's going to be a one-stop service for our ambulant patients. So management of so if they've come for TB medication, we'll do their script, we'll deal with any of their TB adverse events or concerns. We'll also be doing the testing for the COVID-19, and we'll be performing any relevant observations, procedures or examinations as far as possible in that room. The PPE worn by the clinician will be the minimum of the N95 mask with a disposable apron. But if the patient needs to be examined or if a test is taken, then there'll be an addition of goggles or a visor. Very important to discard gloves and apron between each patient close interaction, to sanitize hands and to disinfect the visor, and the clinician must disinfect all the surfaces touched by the patient in between each patient visit. We now have the capability to test for COVID-19, and there are a couple of different ways in which we can do that. The most common way that we're going to be testing for COVID is by sending a sputum test, because most of our patients produce sputum. This is a good sample and a good way to test, and best of all, it can be done outside by the patient himself. If that's not possible, if the patient is unable to produce sputum, then we will be taking the oropharyngeal swabs. Both samples are submitted with a PUI form and contact list form available in outpatients and in all our wards, as well as the normal NHLS form with the barcode attached to the sample bottle or to the oropharyngeal tube. What's very important is that if we've taken a few of these COVID-19 samples, that they must be packed in their own, either a separate black bag or one of those little white cooler boxes, and those bag and cooler boxes must be sealed and clearly marked as COVID-19 specimens. They'll be collected by the normal NHLS courier at 12:30 every day, but the NHLS need to be able to identify that they are separate samples. We can take samples in the afternoons or on the weekends if needed, and the NHLS can be contacted for those samples to be collected. So there's very many places where we can test now. That will be in outpatients, in the chest clinic room. The wards will make areas available where they can do the testing there, and occupational health will be testing our staff members. When we do the test, it's important to wear protective gear. So the clinician will be using the N95 mask in those scenarios, goggles or eye visor depending on what's available, gloves and the disposable apron. Very important that we must change our apron and gloves between each patient, but you can keep your visor or your N95 mask on if you're testing more than one person in a row. And very, very important to wash hands and to disinfect the station between each patient. We're now going to look at what we're going to call our quarantine wards, and very important, these are not COVID-19 wards. These are patients where we're just waiting for the test results, and the majority of these results, certainly at the moment, all the results at the moment are coming back negative. But when patients are in these wards, we cannot be 100% sure that they don't have COVID-19, and therefore we're going to manage them as if one of them might do. We have allocated 6 different spaces for patients admitted, and we've had to separate, of course, male and female, and we've had to separate the different types of TB. So our drug-sensitive TB patients, the men will be going to the PEDS ward. Drug-sensitive TB patients, the women, we've allocated a side ward at females acceptable. For our men who have got MDR, we'll be going to the old male MDR3 ward. For women with MDR, to female MDR2 ward. And then in our XDR wards, there is isolation side wards in both the male and the female XDR wards for patients who is awaiting results. So the rule is now simple. Any new admission will be tested for COVID-19 and will stay in one of these wards until that test is negative. They could be triaged either in OPD or, as we've mentioned earlier, there might be some patients in ambulances that will come directly to the ward to be tested there. If the patient had no contact history and the COVID-19 test returns negative, looks like it's routine TB, then that patient can be transferred back to the normal routine wards. But if the patient has a known contact history, so for example, we know that the patient has either been or worked with a family member or a colleague that has COVID-19, then they will stay in the quarantine ward for 14 days. Most of our patients at the moment is still very low risk for COVID-19, and most of their symptoms will be due to TB. But we're going to have to counsel them that during the few days that they wait for those results, we are going to treat the ward as if there is somebody with COVID-19 in it. So social distancing, very important. Patients must stay around the bed area and not mingle with other areas. The admission time on the quarantine ward needs to be kept as short as possible. So we want to do that COVID test as soon as they arrive. If patients do leave their bed area or when they are being seen by clinicians, they need to wear the surgical masks that are provided. And if possible, it will be ideal to actually do all the feeding and toileting at the bed. If this is not possible and they use the bathrooms, they will need to be disinfected between the use by patients and be cleaned every 2 to 3 hours. To get the wards ready, we have now clearly demarcated our wards into separate clean areas from quarantine areas, and all staff needs to be aware of that. Any staff member that enters that quarantine area will have to don, that means putting on appropriate PPE. So even if a service provider or a visitor or a kitchen member or anybody else arrives, they cannot step into the quarantine area unless instructed by a staff member and with the appropriate clothing. So each ward will have what we call a PPE donning area that is demarcated in the clean area where all the PPE will be laid out. Staff's already wearing the N95 masks and they're going to don gloves if required, the apron and the goggles as per the donning protocol. What's important is that if a staff member is dressed up and walked into that quarantine area, you're going to try and do as many tasks as possible while you're there to be able to limit the amount of times one enter and exit into those zones. We are also going to do only minimal touch observations, so our infrared thermometer, a mobile SATS probe, respiratory rate and pulse rate, and we'll only do blood pressure, for example, if clinically prescribed. So that will help prevent cross-contamination from using one machine to the next machine, and it's not so easy to clean that. When one has completed all one's tasks in that area, the staff member will leave, take off the gloves and the apron as per the appropriate doffing technique in our PPE doffing area, which will be at the exit of that quarantine area. And then after that, they will remove and clean the goggles that they've been wearing for reuse. Now, most patients we'll be looking after, especially at the moment, still have low risk of COVID-19 disease. But as time goes on, we will start seeing patients coming in where we might be very suspicious or where there's a high risk that this patient might have COVID-19. So patients who has suddenly got a lot of worsening of, for example, cough, shortness of breath, sore throat or fever in the last 14 days could be a case of concerns. Patients with a contact history with COVID-19 patients, very concerning. But also patients who arrive very sick with either SATs under 95%, a pulse of over 120, a respiratory rate of over 25, or a fever of over 38.5 degrees. Now, a lot of this could still be caused by the TB, but we are going to manage these patients as COVID-19 until we have those test results back. And those particular patients, we want to be have them looked after by the minimum number of healthcare workers. We're going to still use our PPE as per the quarantine PPE protocol, but if the patient needs bed care, especially our very sick patients, if you are turning the patients, bed bathing the patients, and touching the patient's body, then a full gown will be required. The bed space must be fully cleaned in between patients, and patients must not leave that bed area at all. The patient, if possible, must wear a mask whenever being looked after by clinicians, and certainly when leaving that area. And we'll be treating them obviously for other pathogens while we're waiting for those COVID-19 results. In our cases, we'll obviously have them already on the TB treatment, and if appropriate, also be treating them for relevant lower respiratory tract infections. Lastly, we want to say a few words about our routine care areas and our routine activities at Nkqubela TB Hospital. So although we've already identified our high risk areas or our possible risk areas, this does not mean that there's no risk in our blue areas. Our blue areas are those routine wards where patients have been admitted now once they've got their COVID-19 results back and it's negative, they've got no contact history, or they've been in the hospital for several weeks now. But also our staff areas where staff is moving, like our admin areas, our offices, the OT hall. And in all of those areas, the concern is that there might be mostly the staff members who might have started developing early symptoms or are in that 1 or 2 days before they develop COVID-19 symptoms, and they might be entering into those areas. We therefore want to follow the sort of normal protocols that is being followed everywhere in the country, and have sanitation zones at all of those areas. So we're already having people, staff members included, cleaning their hands when they're coming in at the gate. We want a second opportunity for good hand cleaning in the entrance to all the key buildings. There needs to be a table with a sanitizer and a sign, and cleaners need to regularly clean those tables as well as those sanitizer bottles. And this will include, for example, the counter at reception where one walks in, enter and exit into kitchen, into the admin building, into each of the wards, into laundry room, into the pharmacy, and any area where staff are routinely entering and exiting. And lastly, very important, we also have to have a culture of self-screening. All section managers and staff members must have a very high vigilance of new symptoms in themselves and their staff members or in your colleagues. So if you have a new cough, a new sore throat, a fever or new shortness of breath, please report it to your occupational health nurse, and she'll be able to do a COVID-19 test at that time and advise you further. A huge thank you to the Nkqubela response team who has been getting the hospital ready. The references for this particular presentation is the Infection Prevention and Control Guidelines by the NICD, as well as the Primary Care and Hospital Preparedness Guideline prepared by the Infectious Disease Society of South Africa with Dr. Tom Boyles, Lynn Wilkinson and Prof. Shabir Musa. There will be more trainings focusing on areas in detail such as the PPE.